doesn't mean we can't talk to people. We can't call our relatives. We can't call our loved ones and check on them. Sometimes that extra message or that extra hi, that extra text, or however you choose to communicate with people is exactly what they need to get to the next level. Also want to talk about, the Syndemic Tennessee strategy, where the Department of Mental Health and Substance Abuse Services and the Department of Health has pulled together a strategic initiative to challenge the system and to make sure we take the emphasis off the disease and start focusing on the people and health equity in our communities and making sure that people have access to resources. And we're going to talk about instances of hepatitis, HIV, sexually transmitted infections, substance use disorder, how all of these can synergize in communities to hurt people. But we have a panel group full of wonderful champions that are going to talk about how the resources can all connect and we can aim people back toward that path of recovery. Now, I want to ask something. I'm the director of faith-based initiatives, and I would ask that, can I have just a 10-second moment of silence that respects all faith traditions and people who don't necessarily have a tradition? But just give me a 10-second moment of silence and let's think about those lost loved ones and the people that need that from us right now. Thank you for being respectful. Thank you for being part of this discussion today. Thank you for listening in. I see we have over 150 people that are chimed in today to listen to these champions. So with no further ado, I'm actually going to go into introducing you to who our panelists are and what their expertises are. So the first panelist will be Dr. Orisha Bowers. She's the regional director of the National Harm Reduction Coalition, which leads the Help Connect initiative. This is a Southern-facing grant-making opportunity with goals, and they're to expand syringe service access and harm reduction services to eliminate hepatitis C infection. And I can't wait to hear Dr. Bowers talk and expound on the wonderful work that they're doing across Tennessee and across the country. Next is Mary Lyndon Salters, who is a wonderful, wonderful, wonderful friend of mine. I've done work with her for years in the community as a peer, as well as my job here in state government. She's the director of TADS, the Tennessee Association of Alcohol, Drug, and Other Addiction Services. She's worked as an LCSW licensed clinical social worker for years in different programs since 1996. She has worked in several programs around the state and connected the dots between other programs to help people understand that, we have to operate outside of silos. When we do that and we operate as a system, that we can catch people from falling between the cracks. So I also look forward to Mary Lyndon Salters sharing her expertise today. Next, we have Sam Arbuster, who is the Rural Communities Opioid Program Manager at Choice Health Network Harm Reduction in Knoxville, Tennessee. I'm a UTK fan. In that role, they develop harm reduction programs, build and strengthen relationships with community stakeholders. Sam is dedicated in their work to expanding access to health care for those living with HIV, LGBTQ affirming health care, and harm reduction. Sam, I cannot wait to hear you share your expertise with this wonderful group of people listening, and also to hear you dive in between these trenches with these panelists. And last, we have Shannon Stevenson. She's the CEO of Simple Community Care, a native Chattanoogan and successful entrepreneur. Shannon blends the financial know-how that comes with being a certified public accountant and an unmatched commitment to people in a way that has brought significant forward momentum to people in a way that just gives people a second opportunity to see how our CEOs work around the country and in larger programs. I love visibility and transparency in programs. And her role as CEO at Simple Community Care, she's also been out in the community. And I tried to do a little bit of homework on my panelists before I had the opportunity to introduce them. And I want all of you as panelists to know that I'm very impressed and honored to be on this end listening to you discuss. I'm going to have my pen and notepad out taking extra notes because there may be some other opportunities and possibilities for us to partner with each other. So we're going to break our panel questions down. My esteemed panelists, I would ask that we keep our answers to 3 minutes or less in order to give our other panelists an opportunity to answer and to chime in at some moment. Again, we're great on time today, and I really want to be able to dive into these questions and answer questions for our community at large. People that are listening in, our participants, at the end, if we have time, we will have a Q&A session. I will give you more information on that as we go toward the end of this panel. So right now, we're about to open up and have a good time and talk about how we can be effective in helping Tennesseans get in front of issues that they have and access resources. So my first question, and I'm going to ask my first question to Dr. Bowers. How do you think COVID-19 has impacted overdose prevention in your area?
Thank you. What I've seen is there's the impact of COVID-19 has really slowed down the way in which programs and services are delivered due to, many of the protocols around social distancing, the deprioritization of harm reduction in a lot of programs, especially we fund a lot of health departments and small health departments in rural areas. And so the protocols to prioritize other services and prioritize COVID has caused services to slow down or have to stop in some communities. And what that does is obviously it impacts people's access to be able to get these vital services for their survival. The challenges that come up is increased cases of mental health disparities where folks, we are really excited about telemedicine, but what we know is a lot of our community members don't have access to technology, and so they're oftentimes unable to access those services. There's some challenges around law enforcement policies and practices, further criminalize participants who are accessing programs. And now say the last part of the question is potential opportunities. We could do a better job of coordinating services. We could do a better job of learning and staying informed about what programs are doing. We don't always talk about the work that we do with other folks who do the same type of work. And so that could be helpful in us being able to better things accessible to folks if we did that.
Absolutely. And thank you, Dr. Bowers, for your insight. You brought up a really big issue is access to broadband. We have people that don't have access to the internet, and we tend to want to, sometimes we may forget that some of our people in our rural areas, they don't have a way to get on for telehealth, to get on the internet, to look. They have no type of resource like that. So thank you for bringing that topic up, and I'm sure we will dive back into that again. And I'm gonna carry this over to Sam Armbruster. And Sam, give us kind of your thoughts on, how do you think COVID has impacted overdose prevention in your area, some of your challenges and potential opportunities?
Yeah, absolutely. So I want to echo definitely a lot of what Dr. Bowers said. We know that in harm reduction, one of the things we tell people is to never use alone, but that is directly at odds with what we're telling people in the midst of COVID, right? Social isolation and distancing. So that's putting our folks in a really difficult position. We also know that people are finding themselves having to cope with an atypical drug supply. And so a lot of people are having to get drugs from folks that maybe they're less familiar with or are getting supplied from different sources, which is definitely concerning. We also see that some people are having to change up the types of drugs that they're using, which could put people at a potential for higher risk as well if the things that they're using have fentanyl in them, more fentanyl than they're used to, or they're having to use a drug that they don't have as much tolerance for. And we find that just generally sometimes it's harder for people to get out into the community, to get transportation to our certain service program here in Knoxville. And so that's raised some challenges. Our organization stopped providing services for about 2 weeks at the beginning of the pandemic in order to regroup and determine what services would look like to be safest for our participants and for ourselves as staff. And it's actually given us the opportunity to have some really positive opportunities. Prior to COVID-19, we were operating 2 days a week for about 2 hours per day. And now we're open throughout the week with more hours. And so we're able to see people who our harm reduction programs hours didn't work for them. We're also able to have stronger relationships and more time to talk with people, not only about safer use strategies, but about the things that are going on in their lives. And it's giving us a really great opportunity to even further strengthen the relationships that we have with our participants. So I think that that's been really positive. And one other thing we've found is that people are using fentanyl test strips and testing their drugs more and then reporting that back to us more, which gives us the opportunity to communicate their findings with our participants, which is, I think, a really positive overdose prevention strategy as well.
Absolutely. And thank you for sharing all of that. You know, I'm a fan of harm reduction, and I believe we have to have these open, uncomfortable conversations to be able to connect with people in our communities. A lot of the peer-led conversations can really guide people so we can show them all of these wonderful resources, and people like yourself in communities that have taken challenges and created wonderful and new and exciting opportunities. I look forward to working with you in some capacity in the future. This is our first soiree together. This won't be our last. So I look forward to connecting with you on that organic level. I'm going to now kick this over to Mary Linda Salter. And Mary Linda, will you give us your unique perspective on how COVID-19 has impacted overdose prevention in the area of work that you have, some of those challenges and some of those potential opportunities?
Sure. Ditto to the previous two presenters, but I would say too that one of the real hardships that providers of services have had to implement given COVID-19 restrictions is an actual reduction in beds. And it was certainly not something that people wanted to do, but you can't have a 2 or 4 room bedroom for people in residential treatment in these kinds of conditions. So we've had to limit the kinds of events where we can distribute naloxone. We've had to reduce the number of people that actually can come through the doors. And it's not been an easy process for any of our providers to undertake. But I do know that we have a really strong system, as Bonnie pointed out, of lifeliners, ropes, the regional overdose prevention specialists, and navigators who have regularly contributed to the discussion of how best to reach people in these unusual circumstances. They're the feet on the ground in the communities, and they've really been informative. We've worked with a lot of them to try to change our strategies to adapt to how best to reach people in these unusual times. But I will say that those discussions have really brought to our attention some of the restrictions that Tennessee has put on how naloxone can be distributed, the training that has to go with it, the standing orders and things. And if those are for any reason a barrier, we want to try to take action. So TADIS is considering actually drafting legislation to take to the legislature next year to try to address any of those barriers and to try to make sure that we get access to naloxone for as many people as possible.
Thank you, Mary Linda. Thank you for you always add something greater. You look at the long-term effects and kind of some different angles on how we're going to be able to tackle these issues. Mm-hmm. And lastly, for this question, I'm going to turn this to Shannon Stevenson. Shannon, how do you think COVID-19 has impacted overdose prevention in your area of work, and what are some of the new challenges and potential opportunities? I really like how this panel has been put together, because we're going to get 4 unique perspectives that all tackle different pieces of the same person. So Shannon, with that, I'd like to turn it over to you.
Yeah, so what we know is that people with substance use disorders may also be vulnerable because of the effects on the respiratory system and pulmonary health. Additionally, they're more likely to experience homelessness, incarceration than the general population, and all these circumstances pose unique challenges regarding the transmission of the virus, including COVID-19. So the possibility should be a focus of active surveillance as we work towards understanding that threat. And what we know is that when the rules of a game in a society are suddenly and dramatically upset, people don't know what's expected of them, what they can expect of others, and this can cause a serious shift and increased need. And we have clearly seen that during the COVID-19 pandemic. So let's talk about some challenges. Access to care, transportation, closing, having to reduce hours of harm reduction programs, the increased risk of trauma, fear of the unknown, and how that can increase the use and reliability on substances. What are the opportunities? So we can optimize the time that works best for others, offer more in the community as far as education is concerned. We know that transparency builds trust, and trust is extremely beneficial in building rapport and getting people to believe in your program. So when people know they can believe in you and that you're not going to judge them based on what they're going through, they're going to be more open to using your services and learning about what you can offer. Also, in a lot of our COVID testing opportunities, we've been able to share more about our services, not just to people who have been impacted by substances, but also to the general public, because we know that by more education, we can also get and build support from the community.
Absolutely. And so one of the things that I'm hearing, and I've heard from all of your wonderful perspectives, and Shannon, I really appreciate you sharing your perspective as well, because you said access and trust. We as practitioners, we see the access from the practitioner side. Sometimes we forget that the community might not see the same thing that we see. We may get lost in trying to translate how to help them find accessible resources. So we can't forget about how to get the message out to them, how we can allow them the opportunity to have a relationship with us and trust us, which this leads exactly into our next question. And again, people that are in the participants that are listening right now, I appreciate your comments that you're putting in the chat section. Question number two, how do you see the intersection of HIV, substance use disorder, STIs, sexually transmitted infections, and viral hepatitis play out in your community and the work you do? We all know that sometimes people don't understand how to use person-first language. Sometimes people will attribute a circumstance or a condition to a person without looking at the person first. So I'm going to start this with Mary Lyndon Salter. Mary Lyndon, please give us your unique perspective on this.
Well, certainly all of those things are kind of intersect at the point at which an addiction services or recovery provider touches, a community member, and all of those things are assessed. And while a substance abuse provider can't be the provider that actually implements all of those kinds of either assessments and or treatments, we certainly understand the intersection of all of those and try to develop comprehensive treatment plans that take all of that into effect. I will say that the Bureau of TennCare right now is implementing a program for people with substance use and long-term mental health disorders who also have hepatitis C. And the intersection of that program has led a group of advocates to meet with TennCare about how that program is being implemented and the nature of that program. And one of the things that came out of that meeting was TennCare's agreement that they would start to use peer specialists in how to work with consumers who have those multi-systemic needs. And I think again, while we have some concerns about how that program is being implemented, I think that's a step forward, and actually offering people an alternative that would help them be more engaged in their own treatment, to have that kind of community intersection with a peer who really understands those system issues, I think is key to their recovery. So I'm looking forward to that, and we're going to work with TennCare in the implementation of that program.
Yes, ma'am. Thank you so much for sharing your expertise on that. And Sam, I'm going to come back to you, Sam, and kind of give us your unique perspective on this, dealing with the communities that you serve.
Absolutely. So in our harm reduction program, we obviously see lots of folks who are currently using drugs or are close to people who are currently using drugs. We see folks who are HIV positive. We've given several new diagnoses to our participants, as well as people who are positive for hepatitis C. And we're able to, at point of care, provide confirmatory blood draws for people. So we're able to kind of, while we can't always provide everything that people need, we can see them as a whole person and try to provide those testing services. We also see folks who are engaging in sex work and participants who are just dating and living their lives, right? Like, everyone has some degree of risk for sexually transmitted infections as well. And so while we don't perform STI testing at the exchange, we're able to have open conversations with our participants about reducing risk of transmitting STIs. We give out lots of condoms and lots of lube, and help people figure out what they need to do if they need to get tested. And really, the goal of our program is to mitigate harm across the board and to empower people to take care of their health. And so we do a lot of work to try to meet people where they're at, give them the services that they need and the items that they need to better protect themselves from this myriad of types of illnesses, right? And we find that by doing that, when people have positive diagnoses, they put in extra work to keep themselves and the people that they're near safer. And I think that that's a really beautiful thing. Ultimately, I think that if we try to build systems that look at people as a whole, not as a person who has a substance use disorder or a person who uses drugs or a person who's HIV positive and seeing that alone, but rather a whole person, it gives us the opportunity to create safer spaces for people to have candid conversations about what their needs are, and for us to try to connect them with the services that they want and that they need. Because we want to support building communities where people who use drugs are loved and supported, and not isolated and stigmatized. And we want people to live their fullest, happiest lives. And so I know that's a little bit pie in the sky, aspirational, but I think that it's a really, really great thing to work towards. And I think that doing this work of seeing people as a whole is a really important step towards that.
Absolutely. You know, listen, your expertise is why you're on this panel. So you share it from your perspective and what you see. I'm a long-winded advocate for people, person-to-person, peer-to-peer interactions. I believe that every time you open the door to a conversation like that, you give a person that has needed help an opportunity to then become a champion to help the next person that comes behind them. So I'm really thankful for you. It's not a pie in the sky. It's something that you're going to get done. And you've got a lot of people that will support you in helping you get that done. So thankful for you to share that perspective and you continue to drive that message home. And I'm going to take the question over to my friend Shannon Stevenson, who I just met today. Shannon, I'm excited to have you on here again because you can share your expertise. But Shannon, give us your perspective on this question.
So what do we know about the intersection in our community? Well, we need buy-in, not only buy-in from community members, but support from those impacted. And that takes a really special interest in listening to those who have been impacted directly or possibly family members. So let's look at it from why we as a country began to recognize this. So we saw notable increases of infectious disease, and some of those were directly linked to injected drug use. Then we saw how effective syringe service programs were at preventing the transmission of disease, how effective education programs work at preventing HIV, STIs, and hepatitis C. Then we also saw how harm reduction programs that provide hygiene, access to sterile equipment for individuals, access to overdose and prevention and treatment, health and disease prevention and education, and then linkage to addiction treatment, because those are so beneficial. So when you provide programs that work, it is so much easier to get community buy-in. The other thing that you can do is you can work with some unique partners who, on the onset of implementing this program, you might not see that how beneficial that they can be in supporting your goals and your efforts. And for example, we partnered with some small church groups, and it was groups of ladies who met. They had been family members who had been impacted by substance abuse. And so we asked them, we are going to implement this program, and we would love to have your support. And what they saw was, this could have been a program that could have helped one of their family members. And so they started collecting Tide bottles and other things for us. And so I would just challenge you to look at it from a standpoint of all of us, whether directly or through family or a friend or a loved one, has been impacted by this in some way, shape, or form. And so it's all about how you speak and then also how you listen, because let's be honest, we don't have all the answers, but there are so many people that have had unique experiences that can help us craft what's the best way to impact our community and affect the work that we do.
Absolutely. And thank you for saying that. We always need, if for nothing else, educate the community so they can be a voice of support. Give them an opportunity to engage at some level. They may not have the hands and feet to do heavy lifting, but they could have the voice to tell the community that this is a need that we need in our community. So thank you for sharing that. And for our last panelist, Dr. Bowers, I would like to ask you for your unique perspectives on this question.
All right, so y'all gave me the mic. Remember that.
Yes, ma'am. You got it. Take your time.
You know, I am a native Tennessean, and so I want to preface my statement by saying that we as a community continue to ignore the role that white supremacy, respectability, racism, and stigma plays in the work that we do. We have to address from a holistic and comprehensive standpoint the way in which we deliver services as it relates to those particular issues. Until we are willing to have those conversations, we're going to continue to see some of these issues coming to the surface in the work that we do. We cannot address this stuff from a single issue standpoint. We have to work together. We have to be willing to put our stuff aside and honor our professional commitment to the people that we say we're here to help. So there's no room anymore for us to, have the big I's and the little U's. We have to work together as professionals to be able to address these issues in a way that is comprehensive. And many of the suggestions and ideas that folks on the panel have already shared are great starts for us to begin thinking about that. But we still have to remember that some of these isms can surface in the work that we're doing, and we have to recognize when we're guilty of doing those things. We have to recognize and do our work to make sure we're not continuing to do harm to the people that we say we're here to help. And for me, the way to address those things is to be honest about the fact that we can be the perpetrators of harm, even in our good intentions, and do the work that we need to do to minimize that.
Yes, ma'am. Thank you so much. You made a good point. Sometimes we are in our altruistic zeal to help someone. We may be misinformed or uneducated and ended up doing more harm than we can good. So that's, Shannon said it, Sam said it, Mary Linda said it, and you said it again, time and time again. We have to educate the community. We have to figure out who the champions are and get them to listen. If for nothing else, listen for a minute. So when we respond to people's needs, we can give them something, a good educated response to something that can help them. So I thank you for sharing that. Now, my whole panel, this is the last of these big questions, but this is the biggest one. So please take your time in answering this, and you can deep dive as much as you want. We're actually good on time. This is the most important of these three questions. How can we better collaborate and integrate services to reduce overdose, infectious diseases like HIV, and hepatitis C in Tennessee? This is the purpose of this in the Syndemic response that we have right now. I'm going to read the question one more time. How can we better collaborate and integrate services to reduce overdose and infectious diseases like HIV and hepatitis C in Tennessee? Sam, my new friend, you are the first one on the panel to take a deep dive into this question. So please, have at it.
All right. So I think that in order to better collaborate and integrate care with one another, I think that I'm going to make some pretty broad statements here, but I think that they're important things to acknowledge. I think that it's really important for us as people who are doing caring work to not put our own expectations onto other people. So we need to be really thoughtful about not moralizing or shaming people around drug use, around HIV status, hepatitis C status, sexually transmitted infection status. And we need to have really open and honest conversations with community members who use drugs, who do sex work, and ask them what they need and then actually give that to them. I think that there are a lot of times in programming where we get really wrapped up in, public health jargon and things like that, and we think that we know what people need, and then it ends up not seeing what people actually need. And then it isn't really beneficial because people don't want us to force them to do things, right? I know that speaking for myself, I don't want people to force me to do anything, right? And interrogating if there are demographics, folks not being reached, and why that might be. I think it's really important to name systemic racism, classism, homophobia, transphobia, because a lot of people don't feel safe accessing services because of prior negative experiences, concerns about perceived experiences, things that they've heard from people that they care about and trust. And be an individual's responsibility to overcome those barriers. It's on us as people who are providing services to eliminate those barriers. And I think that we also need to do some work to streamline referral processes because navigating healthcare systems, treatment, social services is a nightmare under the best circumstances a lot of times, right? So there's mountains of paperwork, things that you have to disclose, things that you have to meet in order to receive services. And I think that we need to do a lot of internal work interrogating why we have those barriers and then advocating for removing those barriers. And I think that those are all things that are really important. And I think we need to acknowledge limitations in terms of cost, ease of access, and really shift our thinking towards a more social justice oriented lens in order to make care more accessible. And I think that by doing that, we can work to de-silo organizations and groups' activities because we want to see a world where people have access to the care that they want at the point that they need it. And so the more work that we can do at a local community level, state, and even in federal level advocacy to ease those restrictions that people face and make receiving care less punitive and more inclusive and open, I think is really important. And I think that that's the really hard work that we need to do to achieve the goals that we're setting out to achieve.
Well, thank you so much for sharing. So what I'm hearing you say is a little more cultural competency on the front end can create opportunities for communication instead of barriers in communication. Understanding the community that you're serving and understanding how to speak to them and be friendly with them and be more inclusive of them. So that's absolutely great. And I agree with you 100%. Cultural competency is always an issue. And you make sure that when you talk to someone, you understand the person's perspective, at least validate their feelings enough to listen to them to try to help them find another resource if you can't be the one they need. So I thank you for sharing that. And now I'm going to go to Shannon. Shannon, please offer us your unique perspective. Please don't be afraid to dive deep in on this one. We appreciate you today.
Yeah, thank you so much. So I think what's very important is that we expand programs and access by providing a place that makes people feel safe. So we can put all the services out there, but if people don't feel like they have a safe place to come to, then we're not going to be effective. We also need to train staff adequately and implement trauma-informed care throughout our entire agency, not just in how we treat our patients and clients and the people that we serve, but how we treat each other. Because if we are working with each other in that kind of mindset, then we're going to be able to function better. The people that come into our agency, they're going to be able to see how effective we are and how we treat each other. They're going to feel safe. We need to listen to community members and people who are impacted. We need to listen to them with love and without judgment and actually take heed to what they say. So, you know, providing a panel where people can share their experiences is great, but if they don't see you do something with what they've shared with you, then they're not going to come back to the table, and that's so important. We need to help bridge the connection between the health and the criminal justice systems, because there is a huge disconnect there. We need to work on policy changes that will help stop the stigma related to HIV, STIs, Hep C, and substance abuse. The laws are extremely outdated, and a lot of times just educating the criminal justice system on the advances of medication, how programs actually work and will prevent crime in the community. Those things need to be a priority. We also need to build new and expand on the collaborations with community partners, streamline our processes, make it easier and more efficient. So if people are coming in and they are constantly running into barriers, then they're not going to be all in, and they're not going to believe that you can help them and that they can change. So we need to make things easier, not just for us, but for our patients, because at the end of the day, it should be a very, very easy process for them to come in, to get the services they need, have access to the treatment they need, and when they're ready to get treatment services or even get into care.
Absolutely. Thank you so much. You did dive into that one. Yes, I appreciate you. Yeah, well, you made a really good point. When people come into us to whatever resource that they come to, if the communication is not clear, they're more concerned with leaving than they are with finishing getting the help they need, because they're uncomfortable. And we all understand uncomfortable surroundings sometimes we don't know what people's mental health issues may be. We don't know what their past issues may be. There may be some trauma associated with going to a hospital, a clinic, a doctor, a therapist. So we want to make it as welcoming as an environment as possible so they have an opportunity to engage. So I thank you for sharing that. Thank you so much. Dr. Bowers, I am ready for you to bring it right now. This is your microphone.
All right. I agree with everything all of the panelists have said prior. So I've been editing as I've gone along, but I would like to see us continue to be educated on harm reduction principles and values so that our work continues to embody those principles and values. We need to recognize that people really do have wisdom, knowledge, and expertise on how to solve problems in their lives and in their communities. And so in order for them to bring that information to us, we have to make places in the conversation for them, right? People who are most impacted have to be a part of these planning groups. They have to be a part of these discussions. They have to be at the table in order to bring that knowledge in the room. We cannot presume to know what's best for people. We need to integrate these principles into both our practices and policies within organizations. And if you're unaware of how to do that, you need to connect with people who are making it happen, right? It's nothing wrong with not knowing something. The problem comes in when you don't know and you don't try to find out. So reach out to folks on this panel, other community members who are doing this work, and get involved. Get technical assistance, get the training, find out what other folks are doing that's working, and integrate practices into the work that you're doing so that we can all be better together. We have to engage with all sectors of the community. So that means we have to engage with law enforcement. We have to engage with our faith-based community. We have to engage with youth. We have to engage with community members who are not at the table, but are doing work that could be beneficial and helpful in the work that we're doing. And last, but most certainly not least, we have to stop waiting to be perfect in order to make progress. You don't have to be perfect to take a step, right? Every step is a step in the right direction. So let's stop waiting to get everything together to start doing something. First step is getting involved, getting knowledgeable, finding out information. We could continue to do better if we just move forward. We don't have to be perfect.
Absolutely. Thank you so much for sharing, and thank you for your passion in the work that you do. We really appreciate you and having you on this panel today. My last presenter on this panel for this question is going to be my friend Mary Lyndon Salters. Mary Lyndon, please share your unique perspective on this question. You are muted. Mary Lyndon, you're muted.
Ooh, sorry. I may take the deepest and most multifaceted plunge on this one. I would say that one of the intersections of all of these issues is really around some of the trauma issues that I think impact everybody and lead people to some of these health issues. And I would also interject that would include systemic racism and the impacts of that as well. we need to be able to have a multi-component treatment plan and to have access to all of the healthcare services, that impact these people, because you get an idea of the trauma impact, and you can help, with helping your client understand the trauma impact when you have a multi-systemic, multi-provider treatment plan. There should be kind of a no wrong door approach that gets everybody's issues on the table. And I would add smoking cessation to that as well, because I think that's one of the things that people often turn to as a soothing kind of an element to deal with some of their trauma and to deal with some of the impact of other things in their life. And so I think smoking cessation needs to be a part of this as well. One of the things that you've asked about is integration, and integration is great, but I've worked on integration in several systems that I've worked in, and there are locations for which that works really well. And I want to help make that happen in those locations. But what I've also heard from a lot of PCPs who are trying to implement this is that they are struggling because they can't be an expert in all things. They want to try to do what they can do, but they are at a loss for how to impact all of these systems and to bring it into one location. So I do think we need to look at some other ways of providing multi-systemic care, like co-located facilities, the shopping mall approach, the fact that you can be, your car can be in a parking lot and nobody knows if you're there to visit your PCP, your dentist. The smoking cessation program or the AA group should be something that we think about in terms of addressing some of the stigma, the trauma, and I think the accessibility issues for everybody. You shouldn't have to drive to 5 different locations to get your health care. So I understand the value in integrating, but let's think about different ways to do it. I think telehealth gives us a lot of opportunities to be able to do things just like that. But let's not make telehealth the panacea either. It has its pros, but it has some cons too. So we need a check and a balance, and to have enough of these types of locations and ways to integrate health that people can go back and forth and go to that one-stop shop shopping mall a couple times a year, get that in person, get the telehealth, get the I think the prevention aspect as well. We ought to brand healthcare as healthcare. It's not physical health and mental health, it's healthcare. And that means that there's universal screening for all healthcare issues, and I would include screening for ACEs, adverse childhood experiences, because we're not going to get at some of the basis of some of these things and really do some of the prevention work that would mitigate the long-term prognosis of picking up some of the diagnoses that we've just talked about. So it has to be more systemic. That means it has to include schools, it has to include churches, it has to include your community centers, it has to be a prevention-oriented approach, so that one-stop shop starts to make better sense in almost every community where it can be implemented. And I think I've just touched on the fact that this is about stigma. It's really a stigmatizing condition. And you really need to approach healthcare as healthcare in order to deal with the stigma that's attached to many of the diagnoses that we're talking about here. If it's healthcare, then going to your doctor's office to get your diabetes check or your asthma test or your inoculations, should be just what we do in order to take care of ourselves. I would also point out that at least for addiction, it's the only diagnosis that is really criminalized. And we really need to take a look at our healthcare policies that really haven't kept up with the fact that we now understand addiction to be a disease. If it's a disease, let's treat it as a disease, not just in our healthcare system, but also our criminal justice system. So I think we know as practitioners that forced treatment is not as effective as treatment when people walk in the door freely of their own volition and they understand what they're there to get treatment for. So if we can decriminalize it and make it more of an affirmative step about managing your own health care, I think people will take that step a lot more readily and a lot more freely. Okay, end of my rant.
No, it's all right. It's not. It's positive. It's positive correlation. You and Shannon both mentioned the criminal justice system, and Sam and Arisha are talking about, community collaboration and engagement and acceptance. But if the criminal justice system, if we're doing one thing and they're doing something else, then we're kind of, we're butting heads instead of being a system. So the behavioral healthcare system has to be the behavioral healthcare system. So Mary Linda, I'm always thankful for your words of encouragement and your leadership on topics that we have. So we have probably time for one question. And to my panelists, I'm going to give you guys a minute and a half apiece on this one. So the question came up about PrEP, PrEP, pre-exposure prophylaxis. And to the participants who don't know what that is, it's the way for people who do not have HIV, but who are at very high risk of getting HIV to prevent HIV infection by taking medication. So here's the question: how can we increase access to PrEP and hopefully more PrEP use among people who inject drugs? The first minute and a half is going to go to Sam.
All right. So I think that for me, one of the most obvious ways that we can increase access to PrEP, or really any healthcare, but specifically PrEP for folks who are using injection IV drugs, would be having PrEP intake and point of care, like rapid start for PrEP at harm reduction programs, or having it accessible at non-traditional healthcare settings. Because I think that I've heard a lot of people talk about incorporating various things into primary care, and I think that that's a great idea. But I also think we need to recognize that we live in a country that doesn't have universal or accessible healthcare for a lot of people. Most people that we see in our harm reduction program are uninsured. And so having people who can navigate people to PrEP, help them navigate healthcare systems and get their medications easily and accessibly, while taking into account that people don't have ease of access to traditional healthcare, I think that's one of the biggest things that we can do. And so in our harm reduction program, we are working to expand PrEP navigation when people come to pick up their syringes, to pick up their supplies. And I think that that is a really useful starting place.
Absolutely. Mary Linden?
I would say ditto. I think one of the great things about that shopping mall approach or telehealth is that it can be offered no matter what your insurance provider status. And we all ought to get more used to the fact that, healthcare can be provided for everybody through a lot of public health initiatives, as well as a PCP's office. A lot of the folks who are who come to addiction services, though, have lost access to healthcare or insurance. I'll take another political leap here and say that, the fact that only pregnant women, children, and the disabled are covered in our TennCare program, for example, is a huge barrier to universal health care and many of the things we're talking about providing. So access to whatever you want to call it, Medicaid expansion or just services, I think is key to being able to address all these things in an integrated fashion. If without some kind of universally accepted, provided, and integrated healthcare, then we are talking silos.
Absolutely, and thank you so much. I would like to also extend it to Ms. Shannon Stevenson now. Shannon, can you give us your perspective on this one?
Well, first and foremost, I think that we need to integrate prevention services into basic primary care. So a lot of times this is considered an external or something that you have to seek out separately, but this is basic health. And it should be integrated into all primary care services. People should have access to free testing. People should have access to medication if they want to provide and have safe access. So I think it starts systemically, just like a lot of the things that we're battling right now is that the medical providers need to be trained that this is a very integral part of basic primary care. It's something that should be addressed in every healthcare setting. It's something that should be screened for. We know that we are seeing a lot of risk exposures in certain levels of care, but it should have been accessed at the very beginning. So that's one of the first things that needs to change. And then offering PrEP, we're going to have to, this goes back to policy and legislation. So one of the programs that is most beneficial in us providing cost-effective access to PrEP is 340B. And so grantees have access to this program. It can help assist with copays if that's available and eligible, or if the patient's eligible. And if we lose access to that, then that could provide a huge barrier to getting PrEP to people who need it the most. And so there are several different facets and layers of things that we're going to have to fight. But I would say the first thing is education for the medical providers, that it would be integrated into the UDS and the objectives for primary care visits, that we would also expand the education and access in other settings as well. And then also maintain that we can provide cost-effective treatment when people are ready.
Thank you so much. You're absolutely right. Thank you. Thank you. Thank you so much. On the last, our last panelist, Dr. Bowers, you get to close us on this one. We got a minute and a half, and you've got it.
All right. So I think that all of the suggestions that the panelists prior have said have been awesome, but I would like to take a step back from that and have us recognize that there is a lot of mistrust. Folks in our communities do not trust medical providers. They do not trust health departments. And they're in a lot of cases, their mistrust of us as providers is validated, right? So we have to first do the work that we need to do to reestablish trust with our community members. We can have PrEP falling out of our ears for folks. If they don't trust us, they don't believe that we're there for them and really care about their health and well-being. It doesn't matter how much access we create. It doesn't matter how we could be giving PrEP away, you know, in cereal boxes. Folks aren't going to take it because they don't trust us. And so we need to do our due diligence as providers to show ourselves trustworthy to community members so that they're willing to listen to us and willing to participate in the services that we're providing.
Thank you for sharing. You are absolutely right. Distrust and mistrust are two things that people won't access healthcare or access resources. So, you know, that was a powerful way to end our panel. I want to say thank you personally to our 4 panelists. This has been a great opportunity, a great session. If you could read the comments that people are sending right now, you guys gave 4 different perspectives on something that was wonderful. You really gave some different opinions and different opportunities for people to listen into. I hope that everyone that's a participant will access your resources, access your contact information for some leadership. I know that I will. I want to say one thing before I hand it back over to Amber. I want to say thank you to Governor Bill Lee for recognizing today as Overdose Awareness Day. I want to thank him for his leadership and also thank him for openly advocating for people like myself. You know, I'm a person that's in recovery. I was diagnosed with substance use disorder and a mental health diagnosis. And through the process, we didn't have resources like we have now. So I'm thankful to our governor. I'm thankful to Commissioner Marie Williams for her thoughtful leadership and her partnership with my other good friend, Commissioner Lisa Piercy. They put together a team of champions that have really been out here on the ground doing this work and finding other champions like you panelists. So I'm going to turn this back over to Amber, and I'm just going to say thank you all again. And if you feel free to contact me at any time, you guys are awesome. You'll have a wonderful day.
Thank you, panelists. Thank you, Monty. This was amazing. Couple of announcements. We have a naloxone training following this event. I have dropped the registration to be a part of that training in the chat box. We'd love to have you join us to learn more about this really life-saving thing that you can do for your community. The other piece is all of these panelists are leaders in the Syndemic Tennessee planning process. So if you'd like to connect with them and do more of this really integrated work, I would really encourage you to register for a regional planning group. Each one of these folks is going to be spearheading one of those groups. I have dropped the link to register for a regional planning group also in the chat box. If you have questions, you can feel free to reach out to me at endthesyndemic.tn@tn.gov. And then one other big thing, we did put together an amazing website on the Tennessee Department of Health, the Tennessee Department of Mental Health and Substance Abuse Services, and Tennessee Together, with lots of resources around overdose. So you can access that amazing website with more information about In the Syndemic Tennessee at tntogether.com/IOAD. So I really hope, and I'll put that link in the chat box as well. Thank you, everybody. This was an amazing attendance. We had, I think, 195 people at one point on this call. So I just want to give a shout out to everybody that attended. And once again, thank you so much to all of our panelists. I really hope that you guys can join us for the training in just a couple of minutes. Bye, everyone.